Support for Your Fantastic Mind, provided by Southern Company Foundation. Support for Your Fantastic Mind, provided by the Georgia Department of Behavioral Health and Developmental Disabilities. For more information, visit opioidresponse.info.
Good evening, I'm Jay Watson. 2020 will be a year none of us forget. We are living with the life-changing impacts of a global pandemic, COVID-19. That pandemic has overshadowed another pandemic we were already grappling with across the country and here in Georgia, the opioid crisis. Every day, 128 people die in the United States from opioid overdoses. Add to that the COVID pandemic, which is physically isolating us from each other. From the financial losses to the loss of health, the result is that overdose rates this year are on the rise across our nation and here in Georgia. Consider this. According to Georgia state health officials, between March and June of this year, fentanyl-related opioid overdose deaths have increased by 61%. So tonight, we are beginning an urgent, important conversation, and it's one a lot of people don't want to have because it is uncomfortable. Opioid addiction is often incorrectly judged as a moral failing, but the truth is, it's a brain disease. We are removing the stigma beginning now with straight talk and facts and hope, and we hope to answer some of the questions that you in the audience have sent us, because there is a way forward out of this crisis. The number at the bottom of your screen, 1-800-715-4225, is the Georgia Crisis and Access Hotline. You can call this number at any time in the next 2 hours or any time 24 hours a day, 7 days a week to get connected to resources and help for yourself or for someone you love. Throughout this evening, we'll have a chance to hear from the leading opioid experts in the country. Their insight and advice, combined with the stories you're about to see, are a big step forward in confronting an issue that is harming far too many of our fellow Georgians. This is the opioid crisis in Georgia. From Georgia to Appalachia to California, we cover the country coast to coast to tell this story. There is a dark truth interwoven throughout this majestic beauty. That truth, the opioid crisis, is everywhere.
There's not a community that hasn't been touched one way or another.
We had a war in Vietnam, and we lost far fewer people in that entire war than we lost in 2017 from drug addiction, overdose death.
Families thrust into a war they never saw coming.
We did everything right, by the book.
Children lured.
People may drive into the bluff. Buy, use.
Then hooked.
That was one of my biggest fears, is that my wife or my family or someone would find me dead in a bathroom.
So far from anything you ever imagine your life to be. Like, how did I get here? And how do I get out of this?
There was times when I would be crying, like I don't want to use, and I'd be crying all the way to the drug spot and still use.
70,000 people a year claimed by drug overdoses, a number made more painful when you see the people whose lives held such promise, who were beloved, now gone.
I had all the resources in the world and I couldn't save my son.
He overdosed and actually sat in his car for 22 hours before anyone found him.
I was in this house while my son was dying downstairs, and I didn't know. I just didn't know.
This crisis does not discriminate.
It's everybody. It's mothers, it's aunts, it's uncles, it's doctors, it's nurses. It's people who are homeless, it's people who have 3 homes.
So tonight, we confront the stigma and shame.
It is a disease of the brain, not a moral failing.
We deal in facts, like evidence-based treatment that works.
I think that has been the most important part of his recovery.
And we show the hope that there is a way forward out of this crisis, that recovery is possible.
Our misery has become our mission now.
But first, how we got here. It is a bucolic backdrop, the sort of place where the Main Street barbershop is still the hot spot. But the Appalachian region of eastern Kentucky is a place that has been dragged through decades of a crisis that has ruined generations of families.
There's a lot of dealers everywhere.
Hepatitis C and HIV rates have spiked because of sharing syringes. Kentucky has a syringe exchange program, but only about half the counties in the state have exchange locations. Wolfe County, Kentucky, is the #1 most vulnerable county in all of the United States for hepatitis C outbreaks. Nearby Bath County, where Jason York is the emergency management director, ranks 125th.
Everybody knows someone.
He says opioids are crippling the local economy. That money used to maintain and improve the town is going to the jail, overflowing with people incarcerated because of opioids.
Our county's jail bill in 2014 and 2015 rose in 2017, 2018, 119% to just over $500,000. Now that's money that normally went to fixing roads, implementing social programs, employment, and it won't go there because it's going to a jail bill.
This is a community with some of the highest overdose rates and drug-related arrests in the county.
Dr. April Young from the University of Kentucky has been doing substance use research in these rural communities for 10 years. Not far from that Main Street barbershop is a neighborhood in crisis in Moorhead. And Young needed to recruit participants from it for a study she and her team are doing with Emory University.
We bought a grill and a tent, and we staked out cookouts around local neighborhoods, including this one. And at first, people thought we were crazy for standing in the parking lot and grilling hot dogs in the middle of the summer. But then when they learned more about the study, they were appreciative that we were there to hear their stories about substance use and how their families had been impacted. So they helped us spread the word, and that's how this entire study began.
Emory and Kentucky are collaborating on the project called Care to Hope, studying community responses to the opioid crisis. Kentucky is ranked 9th in the United States for opioid overdose deaths. Georgia is 30th. 1 year earlier in 2017, Georgia was ranked 11th in the nation.
We've developed these coalitions, so there's 72 people involved in coalitions across 12 counties who are guiding the project. And then we've recruited 300 people who are actively using drugs, who we follow over time to study how their behaviors change and how hepatitis C and HIV changes over time, and how we can reduce their risk factors.
At one time, Erica Walker could have been one of the people in the study.
The longest 6 years of my life. The worst, darkest 6 years of my life.
Having lost her brother to cancer and her first baby to SIDS, she became addicted to opioids.
Oxycontin was the #1.
Walker says the initial high was soon replaced by the need to keep withdrawal at bay, to avoid being what many call dope sick. She began dealing opioids, so she would always have a supply. But after getting robbed in a drug deal, she was desperate.
We decide we're gonna get this money back. He goes to a bank, and he robs the bank. I remember just thinking, like, this is it. I've ruined my life. There's no fixing this.
It took a second time robbing a bank before authorities caught Walker and her boyfriend. After getting out of federal prison, she got herself into recovery and applied to college. Now, a dozen years into recovery, she helps people like herself.
Come on, pretty girl.
Oh.
I'm just coming right on up here.
Hi, Bobby. Now I'm a therapist. I work with families with substance abuse issues. I wouldn't take one day of it back if they offered it to me. It saved my life.
The goal is to take what we know from the scientific literature will work to reduce overdose deaths.
Dr. Sharon Walsh is the director of the Center on Drug and Alcohol Research at the University of Kentucky. Kentucky was one of 4 states to receive $87 million from the National Institutes of Health HEAL initiative.
From studies, what we know is that
Walsh and her team across the state will have 4 years to meet a daunting challenge.
Bring an integrated set of evidence-based practices into communities that have been highly affected by the opioid crisis to reduce opioid overdose deaths by 40% in 3 years.
The focus will be on 16 of Kentucky's hardest-hit counties, which will get increased access to medication-assisted treatment, overdose prevention training, and education. The reason this matters in Georgia is because if Kentucky and the 3 other states that received HEAL grants, New York, Ohio, and Massachusetts, are successful, it will be a model that could be used here at home.
Once we're at the end and we can say this works, then we can tell other communities everywhere how we did it.
Here's the map.
Here's the map.
In Cobb County in 2018, 112 people died from overdoses, acute drug toxicity, making them the 2nd leading cause of death in Cobb County behind heart disease. Overdose deaths were twice as common as fatal car crashes. This is one county snapshot, but the story is similar across our state. Some counties are better, some are worse, but all are fighting this crisis. Between June of 2016 and May of 2017, the total number of opioid doses prescribed to Georgia patients surpassed 541 million. Now, to put that into perspective, that's approximately 54 doses for every man, woman, and child in Georgia. 55 Georgia counties have an overdose rate higher than the national average. Here's who we are losing by the numbers in Georgia. In 2018, 866 Georgians died from an opioid overdose. 556 were men, 310 were women, 713 were white, 129 were black, 18 were Hispanic. 68 were younger than 24. 220 were between 25 and 34 years old. 230 were 35 to 44 years old. 165 were 45 to 54 years old. And 183 were over 55 years old. And the newest residents of Georgia are negatively impacted. In 2017, there were 762 cases of neonatal abstinence syndrome, which is what happens to a baby when they are exposed to drugs in the womb before birth. Dr. Claire Coles is one of the world's leading experts on NAS.
Neonatal abstinence syndrome is the physiological response to withdrawing the opiates. So when the baby is born, they're cut off from their mother, of course, and they're no longer being supplied with opiates. And so their body responds as does an addict.
Which means babies suffer from tremors, seizures, fevers, cramping.
Children who have severe withdrawal will frequently be treated medically using other opiates in order to ease the child off and be able to wean them off in a medically appropriate way.
The spike on this chart shows that the number of babies being born with NAS in Georgia was 5 times higher in 2017 than in 2007. All these different numbers lead to the same truth: the crisis does not discriminate. We are a hurting nation. For those who medically need them, opioids are important. But the challenge is to make sure that only those who really need them get them. For example, the same percentage of people in the United States, France, and Italy live with chronic pain, but Americans consume 6 to 8 times as many prescription opioids. Reports from the National Institutes of Health show over 23 million Americans report living with a lot of pain.
You know, I'm a pharmacoepidemiologist, and we study the use and safety and effectiveness of prescription drugs. And one of the principles of pharmacoepidemiology is that the value of a drug is not an inherent property of the product itself. It depends upon how it's used. If you have someone that comes in...
Dr. Caleb Alexander is the co-director of the Center for Drug Safety and Effectiveness at the Johns Hopkins Bloomberg School of Public Health. Alexander and his team examined the policies for Medicaid, Medicare, and major private insurers, looking at their coverage policies for drugs to treat chronic lower back pain. Their conclusion, published in the Journal of the American Medical Association: these policies steer people toward opioid use instead of safer and effective treatments like physical therapy and acupuncture. Commercial plans also made opioids cheap. The median commercial plan placed 74% of opioid painkillers in Tier 1, the lowest cost category. The copay would be $10 for a month's supply.
We do now have randomized trials, however, that demonstrate, for example, for chronic knee arthritis, acetaminophen or Tylenol may do just as well as opioids over the long term in managing pain. The point is that that opioids aren't inherently bad any more than a hammer or a razor blade. It's how we use them that can make them helpful or harmful. And for someone at the end of life who needs palliative pain care, they can be invaluable. They can be invaluable for someone in childbirth or someone that is, has an acute hip fracture. But the point is that they aren't risk-free, and they're highly habit-forming.
The CDC's current guidelines are that non-opioid therapy is preferred for chronic pain outside of active cancer, palliative, and end-of-life care. Research is still teasing out what puts some people at risk for developing opioid use disorder, but known risk factors are genetic predisposition, including a family history of substance abuse, psychological factors such as stress, depression, anxiety, eating disorders, or other psychiatric disorders, and personality traits like impulsivity or sensation-seeking. Environmental factors such as childhood trauma, access to addictive substances, and starting to use alcohol, nicotine, or drugs at an early age. I'm joined now by the Director of Addiction Services at Emory Healthcare, Dr. Justine Welsh, and by the Chief Medical Officer at Hazelden Betty Ford Foundation, Dr. Marvin Seppala. Thank you both so much for joining us today. I'd like to begin, if we could, with the reality that we are all living in this year with the COVID-19 pandemic. And specifically, I'd like to ask you both what change you have seen regarding patients seeking treatment during this pandemic. Dr. Welsh, I'll begin with you.
So first, let me start by thanking you for bringing attention to this incredibly important topic. As far as patient care, most recently in the context of the COVID-19 pandemic, I've seen an increase in the number of patients seeking treatment, as well as the severity of substance use, including opioids, alcohol, and stimulants like cocaine. People are presenting to care who may have been stable in their recovery, then relapsed, or are completely new to treatment. However, I would really say that the biggest change has been how we deliver care through telemedicine or virtual services. It has allowed us to see people more frequently and from farther distances across the state of Georgia than ever before. I'm hopeful that we will continue to provide these services once the pandemic subsides.
Dr. Welsh, thank you. Dr. Seppala, if you could answer that question.
Yes, I'd say the same as Justine. We've gone to virtual services in our outpatient system and had tremendous growth there. But in our residential programming, where people would come in and stay for a few weeks that have a higher need and more risk, there's been a description from our access to care team who takes all the phone calls. And they said that they haven't heard kind of the desperation that they're hearing from people right now in a regular way. On occasion, they would get people that are desperate, of course, but this has become the norm where people just have to get in. They want to get in, figure out a way to get into treatment right now because things are going so bad. And I think it's related to COVID and the excess stress that's going on in all of our lives under these circumstances.
Dr. Seppala, I've had several people reach out to me when they found out that we were doing this special on opioids and say that they live with chronic disabling pain and that opioids are important in their life and that they were concerned that we would be demonizing opioids. Can you speak to that issue?
Yeah, I'd be glad to. Opioids are remarkable medications when used appropriately, and they're the only medications that actually work for certain types of pain and certain severity of pain. I mean, moderate to severe pain in most cases requires opioids. They're fantastic for acute pain, like post-surgical pain. It lasts a few weeks, it's gone. It's severe. Opioids are great. And for chronic pain, though, we're coming to an understanding from the research that they don't work well over time. And that's how we got into this problem, that there was a loosening of the guidelines associated with use of opioids throughout medicine, allowing prescribing for chronic pain and actually promoting it, resulting in the crisis that we're in now. So people that have legitimate chronic pain need to have really good pain docs and pain teams to help them out to figure out alternative ways to address that pain than opioids. Now, that's not everyone. It is most people. Most people can get by without opioids that have chronic pain. There are certain people that require opioids, and they need to have those medications, and they need really good teams, really good physicians that know that type of pain and know those medications, because the risk is so high.
So if you're legally prescribed opioids for short or long-term use, are there things that you can do to avoid becoming addicted or warning signs that you know to even look for?
Yeah, the first thing is, are you using them as prescribed? That's a big feature. People start escalating their dosage, taking more than prescribed or taking it more frequently. That's a bad sign. It could be related to ongoing pain, and that needs to be evaluated, but it could be related to addiction. I would say to get other people in your life to help you to structure this, to kind of reduce risk associated with these medications and overuse of them, ultimately could lead to addiction. But if you have other people kind of helping you monitor it, that's beneficial. And it's important to discuss risk factors with the prescriber, because sometimes they're not going to mention this, but if you have a family history of addiction, or you have a history of addiction or misuse of psychoactive substances, it's possible that you are at risk for addiction, higher risk than the general population. And as a result, that discussion is really necessary, and those risk factors have to be taken into account. You can still use opioids, but it would be a much more controlled situation, much more monitored situation. It's important, of course, to have Narcan available, the antidote to an opioid overdose if you are taking these medications. And if you have a family history of addiction, or you have a history of another mental illness, or you have a history of some sort of life trauma, whether it was a war trauma, bad car accident, sexual trauma, that sort of thing, you are at higher risk, and that needs to be discussed with the provider and precautions taken as well. It's important not to mix opioids with other intoxicants, more likely to be problematic and perhaps lead to addiction. And if there is overuse, if family members notice, or someone else brings it to the individual's attention, or the person kind of recognizes, I think I'm getting out of control with this, it's really essential at the early stages to get back to your doctor and discuss that, and perhaps seek evaluation from an addiction expert.
Thank you, Dr. Seppala. Dr. Welsh, one of the biggest issues facing Georgia right now is access to treatment, providers, and services. Can you talk about that?
This really is an issue across the country. The vast majority of people who need treatment don't receive it. There simply aren't enough addiction treatment providers and resources. And for the few individuals who may be able to access care, there are often significant barriers like distance to a treatment center, affordability of that care, and having to overcome stigma that is often associated just with having a substance use disorder. It's because of these reasons that Emory University and the Hazelton Betty Ford Foundation have recently formed a collaboration called the Addiction Alliance of Georgia. The Alliance seeks to align with ongoing public and private efforts while partnering with diverse stakeholders to provide comprehensive treatment and recovery support to both insured and underserved people in Atlanta and Georgia. With this collaboration, we plan on expanding clinical services so that they are accessible and available across the state through telemedicine. We'll be focusing on educational initiatives ranging from school-based prevention programs to training prescribers around addiction. We are also developing a research component that will look for answers about best practices and new and innovative ways to approach care, all of which can be applied to Georgia.
Dr. Welsh and Dr. Seppala, thank you so much. We're going to continue our conversation with you a little bit later in the show. Thank you again for being with us.
Thank you.
Thank you.
Opioid use disorder is impacting thousands of families across the state at this very moment. Remember, you can call the Georgia Crisis and Access Hotline number at the bottom of the screen to get connected to state resources for yourself or a loved one. That number is 1-800-715-4225. Now, it's time for a trip inside our brains to show you what opioids do to our brains and how we become addicted. And we introduce you to medications that can be life-altering and life-saving. But first, some families willing to share their stories of what happened when opioid addiction entered their lives.
Purple was his favorite color. I have my favorite Mother's Day card. I love you very much. I honestly didn't know what an opiate was. Christopher in 8th grade was diagnosed with ulcerative colitis. 15 to 18 times a day you're having diarrhea and horrible stomach cramps, and for a boy in 8th grade it was horrible.
By the time Cami Wolf Rice's son was a senior in high school, he had surgery to remove his large intestine.
He had so many complications. He was in the hospital for 70 days, on morphine for 70 days. So really, at that point, I mean, now that I know all that I know, he was doomed then at that point, before we even got the 90 Oxycontins that we went home with, and then the refill of 90 more. I was timing it. I was like, okay, honey, you just need to stay one more hour, you can have a pill. So yes, I was feeding him those Oxycontin. There was never a conversation ever about anything about addiction.
I've never in my life seen my mom so happy. It's so important to me.
Christopher was out of college and living at home before Cami would learn her son had never stopped taking opioids.
I was talking to Christopher at the table, and he literally fell asleep at the table in conversation. I can't even tell you how shocked I was.
Inpatient opioid treatment began. Relapses always came. Unable to get prescription opioids, Christopher eventually moved to heroin. How many times was he in treatment?
5, I believe. 5 different treatments. This is a bracelet that the Cambodian grannies made.
On a trip with his mom to Cambodia to visit the school she and her husband had opened for children there, Christopher overdosed and died in their hotel room while she slept.
There's nothing worse. There's nothing worse than a parent losing their child. There's not even a word for it, because there is no way to describe it. And I'll never be okay. I'll never. Every morning I wake up, I think the first thing when I open my eyes is another day without Christopher. Look at the smile on him. He's just beautiful.
In those 5 times in treatment, Cami's son was never offered medication-assisted treatment.
The first time I heard about it, I was in a meeting with a doctor. I got in my car and bawled like a baby because he didn't have that opportunity.
Patient 1136, please come to window 1.
Here's medicine, 30 milligrams.
We have evidence-based treatments for opioid use disorder. Someone who is on medication-assisted treatment, they double their likelihood of achieving abstinence in periods of early recovery.
There are 3 FDA-approved medications: methadone, buprenorphine, and naltrexone. The popular names are Suboxone, Subutex, and Vivitrol. Director of Addiction Service for Emory Healthcare, Dr. Justine Welsh.
There's a significant stigma against these medications. There is this concern that if somebody is on a type of medication-assisted treatment, that they're not truly abstinent. They're taking some sort of drug. And in reality, that's just not true.
To understand how these medications work to help people remain abstinent from using opioids, we need to first take a look at what happens to a brain on opioids. Our brain is filled with opioid receptors. When the brain is stimulated by things we find pleasurable, such as eating, social interaction, or sex, these receptors are activated and cause dopamine to be released. When someone takes an opioid, it is much more potent and causes much more dopamine to be released, which can cause a rush of euphoria and a sense of well-being. For a person in pain, this can alleviate that pain. The more someone takes opioids, the more the brain adapts to having them around. It's called tolerance. You need more and more to relieve the pain or to get high. Oftentimes, people have to take higher doses to control withdrawal symptoms, such as aching, fever, diarrhea, vomiting, sweating, and chills. Now to the medications that treat opioid use disorder. With the controlled use of methadone and buprenorphine, both activate the opioid receptors just enough to prevent an opioid-addicted person from feeling withdrawal or cravings, but not enough to get them high. This helps prevent relapse while their brain gradually heals. Naltrexone, a once-monthly injection, blocks opioid receptors and prevents the opioid from having its usual effects. A life-saving emergency medication is naloxone, more commonly known as Narcan. It's an overdose-reversing drug that blocks the effects of opioids on the brain, restoring breathing to an overdose person. The use of heroin has been increasing in recent years among men and women, most age groups, and all income levels. Some of the biggest increases have occurred in groups with historically low rates of heroin use: women, the privately insured, and people with higher incomes. 3 out of 4 people who use heroin report misusing prescription opioids first. People often move to heroin when access to prescription opioids is cut off. Fentanyl is cheap and easy to make. Just a tiny bit of it added to another drug can make it more potent and deadly. In Georgia, the greatest increase in opioid deaths was seen in cases involving synthetic opioids, a rise from 61 deaths in 2012 to 349 deaths in 2018.
So I started working in...
Dr. Hannah Cooper is the chair in substance use disorders at the Rollins School of Public Health. She shared a dramatic example of just how much illicit fentanyl has infiltrated the drug supply. This is what happened for a study Cooper and her team were doing with heroin users.
So we had a lot of people coming in to be screened to take part in the study. They would report, using opioids, in the past 24 hours, X times a day, and then they would be negative, and that always happens sometimes, but we were puzzled that it was happening more often than we had expected. And it turned out that everyone in our sample, or everyone who we were recruiting into the sample, they thought they were using heroin, and that's what they were reporting using, but they were testing negative for opioids because they were actually using fentanyl. And so we've had to change the urine test to capture that.
According to the DEA, fentanyl is manufactured in clandestine labs traced to Mexico and China. It is often sent to the United States through the U.S. postal system.
They may have first come across an opioid because of a wisdom tooth extraction, or might have had some type of sports injury that they received opioids.
Brian was big, he looked like a football player and he looked like an athlete, very tall, but he was very slow and very uncoordinated. So he was
lumbering when he ran would be the word a couple of coaches described him as. Always smiling, just a really easygoing kid. It started with Percodan with surgery when he was 16. He had an infected lymph node in his armpit.
Years later, Brian Waronker would tell his parents that that first Percodan put his life on a different path.
He said the minute that first one kicked in, I had never felt so good in my entire life. I loved that feeling, and I loved getting high.
There was months of inpatient treatment and even 5 years of recovery, then an overdose in Las Vegas.
And we had literally written his obituary and epitaph on the plane to Las Vegas when I didn't think he was going to wake up.
Brian recovered from that overdose only to relapse again, taking a dose of OxyContin that proved to be fatal.
What's sad to me is that he had this horrible disease. He just wanted to be a normal kid, and he couldn't.
Steve Waronker is an anesthesiologist. He knows opioids well. He and his wife Mitzi sat in family sessions in rehab centers, hearing the same story from other families.
Everybody had the same story. Their son said the very first time they had surgery, the very first time they had that pill, they never felt better in their life.
When his autopsy came back, it was cocaine, heroin, but it was the fentanyl that killed him.
Frankie McCaffrey was a good kid, happy, loved, easygoing.
Anyway, he was just a great kid. He was loved by everybody. And actually, this is a lovely photo of Frankie when he was 4 years old at our wedding.
In his 20s, he began using drugs. He changed.
It stole away his whole personality. It wasn't Frankie anymore. It was somebody completely, it just stole his whole personality away from all of us.
When Jeanette McCaffrey, an OR charge nurse at Emory University Hospital, realized her son was using heroin, she and her husband sent Frankie for inpatient treatment. He was there 3 months. She hid from her coworkers what her family was going through.
But I kept it to myself, you know.
And why?
Because of the stereotyping. I didn't want people to think Frankie was a loser, because he wasn't a loser. Oh, I think it was here. And I realized I had an addiction that was becoming a problem when I couldn't do anything without doing dope.
Like so many families, Jeanette was doing all she could, even on the night of Frankie's fatal overdose.
You know, it came back that Friday night, we talked, and, you know, didn't even talk that much. I even did a urine test on him. I said, Frankie, if you come into the house, we've got to make sure you're clean. Did a urine test on him. And that was negative, so it was all fine.
She didn't go downstairs to his basement bedroom until the next day.
That's something I have to live with. I was in this house while my son was dying downstairs, and I didn't know. I just didn't know. I had Narcan right here. If I knew, I would have, you know, but I didn't know. I just didn't know.
Sometimes you can't get far enough away.
I'm 32.
Stephen Boykin is 2,100 miles from home in San Diego, California.
Certain things triggered me. I remember seeing the city skyline was a big trigger for me.
I didn't grow up in anything like this or having friends like this.
Cece is Stephen's wife. What she's talking about is what happened when this Cobb County native who played football at Walton High School got an injury and the doctor gave him opioids.
I had some injury that happened, and I remember just feeling like shit and taking a few of those pills, and then just being in my bed, and all of a sudden all those pains and worries and problems that were in my life all of a sudden kind of just disappeared, and this warm blanket was wrapped around me and all my problems were gone.
The great truth of that first opioid high was that all of Stephen Boykin's problems were about to begin. He took more pills. He crushed them, snorted them. Same with anything he could find in his parents' medicine cabinet, which was in the pantry.
Me and my friends would go in the pantry, and instead of coming out with a snack, we'd find, her bottle of hydrocodone and snack on those instead,
He moved to OxyContin, eventually to heroin. Stephen Boykin will tell you he had a happy childhood.
Very loving family. So yeah, nothing outside of the ordinary.
So did his friends who got addicted.
Grew up in a really good family. Parents are married, younger brother like me, same thing though, got caught up, played sports in high school, got caught up in the wrong crowd and loved drugs a little too much, and that's, I could tell you 30 other people that I'm close with that have that same story.
These good kids became masterful liars, had to learn to steal to support an addiction that blotted out everything else.
It's like a Dr. Jekyll and Mr. Hyde type thing where I could be an outstanding moral, righteous citizen and not have any, not even think about doing anything wrong. And then if that craving were to kick in, I could all of a sudden, be willing to steal from a grandma or a baby or, hurt someone if it can help me get what I need.
Nobody thinks that their 9-month-old infant is going to grow up to be a drug addict.
Frank and Karen Boykin would discover Stephen's addiction when he was home from Georgia Southern University for Christmas break in 2010.
I was up early balancing my checkbook, and I noticed that there were several consecutive overdraft charges, each above $1,000, hitting my account within just a few, like a couple days.
I remember he took me up into his office and locked me in there. Like my mom was trying to get in the door to talk to us, and I told him, I was like, I'm addicted to painkillers.
My first reaction was anger. How could you do this?
They took Stephen to the hospital and were told he could detox at home. They learned this was bad advice.
His legs were shaking, his arms. He was sweating, he was throwing up. It was very scary seeing this. They said he wouldn't die, but he would feel like he was dying. But I really was afraid he might die. I prayed a lot during this that God would help him through this pain, this agony.
Then came inpatient treatment all over the country.
He was committed. He showed a level of commitment that was encouraging to us, but we didn't understand what was going on in his brain.
Relapses always came.
They thought that it was just me being kind of, I don't want to say lazy, but just giving up. Yeah, weak. And that I should be able to control it better.
Karen and Frank Boykin will discover they must do what seems impossible in a dramatic last effort to try to save their son. Cami Wolf-Rice, Christopher's mom, joins us now. Cami, thank you so much for being with us today.
It's great to see you, Jay. Thank you for having me.
I know you have dedicated your life to education and prevention, and we're going to be showing some of that in a few minutes. But what I would love for you to talk about now is something I think a lot of families need to hear someone address, and that is the stigma of addiction, the shame you felt because your son was addicted. And I know that you are so far beyond that now, but if you could, if you will, take me back to then, talk to me about the stigma and how it impacted you and Christopher.
It's interesting you say that, Jay, because watching the documentary and the interview, when you said Christopher did the heroin, it still struck my heart. And the reason is that we've criminalized addiction in our country. And my son wasn't a criminal, and to think about the language that we use when we talk about people fighting substance misuse. It's a drug abuser and a drug addict. And it's a little controversial, but I totally disagree with people having to stand up every day in treatment and say, "Hi, my name is Christopher and I'm an addict." I mean, it just used to devastate him to have that label put upon him because it had such that negative stigma. Yes, there are criminals that fight substance misuse, absolutely. But is everyone a criminal that has an issue? No. And that's what breaks my heart, because I know that the last thing I wanted is for people to think my son was a bad person. He was loving and caring and a good human being. And we've got to start portraying people that are suffering and that are dealing with substance misuse as human beings and not in a separate segment in our society. It's heartbreaking, to be honest.
So what would your advice be to families who would find themselves in this position now of trying to help a loved one dealing with addiction?
Well, you know, I've always heard that addiction is not the casserole disease. You know, you don't tell your friends and your family and your neighbors aren't bringing over casserole that you would do if you knew somebody had cancer. And the bottom line is, it does take a tribe. It does take such a strong group around you to support you through these times, and you can't be embarrassed. But the issue is, nobody wants to look bad, right? Nobody wants to be thinking that they failed as a parent. You didn't fail as a parent. This is a disease. When someone's diagnosed with cancer, you don't say, well, what did you do that your child got cancer? So you have to ask yourself those questions, treat it like a disease. And the support that you can give is love, understanding, compassion, empathy, not blame, not shame, not disgust. Does that make sense?
Yeah, it makes total sense. My last question for you is one that I think we have a tendency as human beings to look back and wonder if we could have done things differently. And I know that you received an education that you never, ever wanted. But what is something that you wish you had known at the beginning of this journey?
I wish that I had questioned the doctors. You know, I don't blame doctors, honestly. I mean, I do blame Purdue Pharma. Honestly, they did kill my son, but I would have asked the doctor more questions. Why, is there any dangers with these pills? I didn't even know to ask that question. We assume that prescriptions means safe, and it doesn't. And you can become addicted on one prescription. So I wish that I would ask more questions. I wish I would have paid attention to more signs that Christopher gave me, behavior changes, excessive sleeping, lashing out, just paid attention to more of the signs that he was giving me, that he was still suffering and that he was still taking the medicine because he hid it. And again, that ties back to the stigma. I think if people are more comfortable to talk about it, they're also more willing to go get help. As we now know, 1 out of 10 Americans get help with substance misuse. We've got to fix that. We've got to be open to talk about it, to get that help.
Cami, what I love is that your story is far from over. And in a few minutes, we're going to be able to show people everything you are doing to prevent this from happening to other families. I cannot thank you enough for being with us today. It's great to see you again.
Thank you, Jay. And I'm sorry, if I could just say one more word about the MAT program. Don't be afraid of getting assistance for your loved one with a medical assisted treatment. To me, it is absurd that we're even having a conversation of whether or not you should do it. If you have medicine to save someone's life, why is that even a conversation? You get chemotherapy if you have cancer. You get insulin if you're diabetic. If there is a medical assisted treatment that could save your life, why would you not do that? If I had that opportunity for Christopher, right now you might be interviewing me as one of the mothers that their child survived this and is on the other side, but you're not.
That's a very good point. Thank you for sharing that with us, Cami. And I can't wait to show people the rest of your journey and all that you're doing shortly to come in the program. Thank you, Cami. Great to see you.
Thank you.
I'm joined now in the studio by the immediate past president of the American Medical Association, Dr. Patrice Harris, and the commissioner for the Georgia Department of Behavioral Health and Developmental Disabilities, Judy Fitzgerald. Thank you both for being here. We're thrilled to have you today. Now, because we are in a pandemic, Commissioner Fitzgerald and Dr. Harris are more than 8 feet apart, and we were all socially distanced and masked until the taping of this segment began. Thank you very much. I want to go back to what we just saw, Cami Wolf-Rice. She's a mother who lost her son, and we know too many families in this situation. So let's dive right into this. We saw in the video that her son was never offered medication-assisted treatment, many times in treatment. Dr. Harris, why is there such stigma against this treatment?
You know, it's so hard to see that because we know what works. We know that medication-assisted treatment is evidence-based. The data is clear. Those who have an opioid use disorder do better than those who do not have access to medication-assisted treatment. You know, I think there's still a stigma. You know, there's a stigma associated with having a substance use disorder anyway, and such a stigma with medication-assisted treatment, even within the treatment and recovery community. And I believe what's driving that is inaccurate information and misinformation. So let's just start with the science, and we should make sure everyone has an equitable opportunity for MAT treatment.
Commissioner Fitzgerald, what do you consider Georgia's biggest challenge when it comes to this epidemic? And what are some of the things that are needed to move the state forward?
So I think there are a few challenges. You've heard over and over the issue of stigma. And it's such an important and fundamental challenge because if people don't, first and foremost, don't recognize that addiction is a disease, they're already going to be stigmatized. So accepting that addiction is a disease, accepting that it's an equal opportunity disease. It doesn't care what age, what race, or what your economic status is.
Right.
Addiction can be a part of any of our lives. So recognizing those fundamental truths is important. Once you accept those, then you can start to accept, just as Dr. Harris was saying, that treatment is available and treatment does work. And there are many paths to recovery. The most important thing is to break through that stigma and make it possible for an individual to say, I think I need help, and to reach out to others when they believe that they do.
Another question for you. How can the Addiction Alliance of Georgia best support the state's efforts?
So we were so pleased to see the Addiction Alliance of Georgia come together. Here's what's really great about what's happening in Georgia and why we're so proud. That really was led by private sector individuals, a leading academic institution right alongside a national treatment provider organization who the state of Georgia already had ties with. And right from the beginning, they said, how do we make sure that underserved and uninsured individuals are a part of the conversation? And they invited our organization, DBHDD, to the table. And what we came to recognize right away is we're at our best when the public sector and the private sector are working together on behalf of Georgians in need.
And I know that we all agree education is a critical piece of this initiative. So can we talk about the importance of educating healthcare professionals in the state of Georgia regarding MAT? And this can be for both of you to talk about, too, the importance of that education.
Well, I'll start. And as you are aware, I have chaired the AMA's opioid task force since its inception. And one of our first recommendations was to encourage physicians to increase our education around MAT, around pain, appropriate pain care, and around opioid use disorder in particular. So education is key. You know, and physicians do that all the time, right? We get a continuing medical education credit. And so certainly we have the data to show that physicians wholeheartedly embraced continuing our education and becoming more educated on all three of those topic areas.
And I'd like to add, when
DBHDD received the federal grant, the Federal Opioid Response Grant. This was an important area of investment, doing everything that we could to make it possible to make training available for physicians. But in addition, one of the things that we really tried to do was understand what are the barriers, not only to being trained, so you might be trained, but then why aren't physicians taking on more patients, right? As we see the addiction crisis really emerging throughout the state, really talking to physicians and trying to break down those barriers about what would make it more possible for you to open the door to see more patients. One of the things that we learned was that some of the physicians did not feel like they knew enough about the resources that were available in the community. So, because once you may go to treatment, be successful in treatment, but it's also you want to be able to link your patients and their family members to the other resources that are available. So we've made a really strong effort in the state to partner with the physician community and really understand what stands in the way, not just of the training, not just to understanding, but really advancing clinical care and then connecting to resources to lead a life of recovery even beyond treatment.
Dr. Harris, earlier in the program, we discussed how insurance companies drove people to opioids. Can you talk about other medicines that are effective for pain and the alternatives that exist?
That is a critical part of the conversation and really, I think, amplifies so many barriers, not only to treatment, but also to alternatives to pain care. Because as we talk about the opioid epidemic, it is so important to talk about it in the context of pain care. And we saw, through our research at the AMA, that, it is absolutely quite easy to say, please recommend an alternative to opioids for your pain care, but those alternatives are not always equitably available, such as physical therapy or biofeedback. And the other piece that we don't talk about enough is you really have to have access to affordable, meaningful health coverage to even think about physical therapy, affording physical therapy. And then you have to think about paid time off from work, transportation to the physical therapy center. So we really need to eliminate all barriers, but those barriers that payers put up, such as prior authorization and step therapy, have to be eliminated immediately.
Another question for you. As you said, you chair the AMA's National Opioid Task Force. What's happening at the national level that could impact and help us here in Georgia?
Well, again, to highlight the importance of a national framework to look at eliminating the barriers. Now, state insurance is regulated, or health insurance is regulated at the state level. And so we certainly have at the AMA called nationally on the state health insurance commissioners to look at any barriers to care. And a key area is parity. Parity has been on the books for over a decade. Federal parity laws. Some states even went further, but we've not gone back to see if our payers, our insurers, are following those parity laws. So those are just two of the many areas from a national level that we are looking at to make sure that these things are happening on a state level.
I'm wondering if one of the last things we can talk about, and Dr. Harris, I'll begin with you, is the racial disparity that exists in the opioid crisis. Can we talk about that a little bit?
We absolutely can, and I have highlighted this, and as currently we are now in the midst of this COVID-19 epidemic, which has brought into stark relief health inequities in our country that already existed. They existed around a lot of chronic disease. They existed around the opioid epidemic, and particularly in our response to the opioid epidemic. In the 80s, when most of the folks who were having trouble with this addiction, with opioid use disorder, and it was heroin, our country's response was incarceration. Now that we've seen an increase in a lot of the folks who are impacted are middle class and upper middle class white Americans, we see a change in our response to treatment. Now, as a psychiatrist, I am glad to see that change in response, but we have to appreciate our inadequate and unfair response before and make sure, actually it's even more important to make sure that everyone has access to medication-assisted treatment or other therapies for an opioid use disorder.
Yeah, if I could just add to that. You know, as I mentioned earlier, you know, addiction as a disease is sadly an equal opportunity disease and pays no mind to your age. As we saw in the video, so many families all around the state are impacted. And so in the same way we know that it can impact anyone, we're working hard to make sure access to treatment and all paths to recovery are available for people all throughout Georgia. And that's really the reason our department has prioritized. Our priority population are individuals who are uninsured, but making sure we're working in partnership with community providers to ensure that medication-assisted treatment, peer services, recovery, and all the other ways that people might take that first step are available all throughout the state, and we'll continue to do that.
And it's an important conversation that we clearly need to continue. Commissioner Fitzgerald, Dr. Harris, thank you so much for being with us today.
Thank you.
Jay, thanks for your interest.
A reminder that you can call the Georgia Crisis and Access Hotline number at the bottom of the screen to get connected to state resources for yourself or a loved one. That number is 1-800-715-4225. We're going to pick back up the story of Stephen Boykin. Addicted to opioids for years, his parents trying everything to help him. Like many families, they felt they had no good options left.
All of my hope had disappeared. We were doing all the right things. We were attending meetings. Stephen had gone to treatment, and we were doing everything right, but he kept relapsing.
They had done everything. As chief financial officer of Mohawk Industries, Frank had made countless high-stakes decisions in a multi-billion-dollar industry. Yet no amount of right decisions or intentions was saving their son. Frank and Karen were told it was time to cut ties with their son, a last-ditch effort to save him. Karen remembers being told,
if you allow him to come home, he will probably relapse and he may die in his childhood bed. So where do you want him to die? Do you want him to die on the streets of Atlanta, or do you want him to die in his childhood bed because you have provided a roof over his head, food, finances, that sort of thing?
They cut him off.
And he just said, you don't love me anymore. How can you do this to me?
I remember that was like a big, eye-opener for me, because that was the first time they had ever actually kind of cut me out, so to speak, from even communicating with them. I had always been able to at least talk to my parents about my problems, and this was the first time they didn't want to hear it. They were better off just not talking to me.
Stephen was homeless for over 2 months. It would be his 5th time in treatment at Hazleton Betty Ford in California. That was the first time he was ever offered medication-assisted treatment.
So this is Suboxone. Doesn't taste the best, but besides that, it helps me from living the heroin junkie lifestyle that I was living for years. So this is a lifesaver. Friends, come on, roll over. You got it. Roll over, roll over. Good.
Is that a trick if you have to push him? He has been in recovery for 3 years.
Where would you be today without medication-assisted treatment?
Could be dead. The cravings and the thoughts and the urges, they're not really there anymore. Cool piece right here. 25 if you wanted it. I like the colors on this one. Life is amazing right now. Here it's going to be all Harley Davidson. Shortly after I started taking Suboxone full time, I do them both for 30 if you want it. Really started to focus on, this one's like 40. My passion. Well, if you get it with everything else, I'll cut you a deal and do it like for $10 or something,
Stephen and Cece opened a vintage clothing store.
Pretty much, we got a bunch of 80s and 90s clothes in here.
Open for 2 years, Vintage Threads and Grails in Pacific Beach is already in the black.
I think it's the nostalgia behind it.
Probably about after a year of being on Suboxone, I could see parts of the old Stephen come back. He would call and say, how are you doing, Mom? What? You never ask about me. What's going on with you? And there was a protectiveness now, like the old gentle Stephen was back.
Their painful journey through America's drug treatment system with their son had given the Boykins an education they found lacking. With the help of other business leaders in Atlanta, Boykin approached Hazelton Betty Ford and Emory Brain Health about collaborating on an ambitious project to bring evidence-based treatment, education, and resources to Georgians. From telehealth treatment for people across the state to an outpatient program to education of physicians throughout Georgia on medication-assisted treatment, the program will launch in the coming year.
Treatment works and recovery is possible, and we're going to be able to show that in a greater way in the state of Georgia by the two of us coming together.
We can combine our neuroscience strength and our strength in understanding trauma with their tremendous strength and experience in the treatment of substance use disorders. With the strength of their national network, we'll be able to ask and answer questions that others haven't been able to do.
I'm tired of seeing people with the disease that I have die of overdoses from opioids.
Hazelton Betty Ford knows this journey. It has not abandoned the core 12-step program, but in following their patients with opioid use disorder, they saw a huge spike in deaths after leaving treatment. That's because people who are abstaining from opioids are at high risk of dying. Just one slip with their lowered tolerance can be fatal. 8 years ago, they added medication-assisted treatment to the program.
At the outset, there was a clear fracture in the recovery community. I think it's gotten a lot better as the idea that it saves lives has become very apparent to everyone. Our data is coming back now. It is saving lives. It is working. When you're taking a medication that is prescribed by a responsible physician who is skilled and trained in the area of addiction for its intended purpose, for its FDA intended purpose, you're not relapsing. You are taking care of yourself the way that you should, and you are sober. You are in recovery.
He overdosed and actually sat in his car for 22 hours before anyone found him. We had an APB out on him, the whole 9 yards.
Davis Owen had his first opioid at 18 after he got whiplash in a car accident as a teenager. Just 2 years later, 6 weeks out of rehab, he overdosed on fentanyl-laced heroin and cocaine.
We're at The Zone. The Zone is a 21,000 square foot recovery support organization, and our goal here is to help people in recovery stay in recovery. So we are the first and only recovery support organization in Cobb County. And last month alone, we had over 3,200 visits here for people to get out of their head and receive the services that they need to stay in recovery. Davis was 20 years old in this photo, and that's the year that he also died.
Missy Owen created what Davis did not have when he got out of treatment, a place to connect socially, to get free resources and services.
The meetings we have now are about 36 per week, and we have parent meetings, we have adolescent meetings, we have the 12-step meetings, we have all recovery meetings, we have medically assisted, we have LGBTQ, we have every kind of meeting that we can think of because we support all pathways to recovery. The Zone is the model for the state of Georgia. We've been proclaimed a local, state, and national model. We're actually in 12 states now with our replication toolkit. You can go one of two ways when you lose a child, and you can never come back from that, or you can do something about it.
The Christopher Wolf Crusade is Cammie Wolf Rice's way of doing something about it.
In his honor, we are fighting this epidemic.
She is focused on prevention, taking this message to children.
My goal is to have the CWC certification in every school, every youth program, to license it to anybody that wants to teach it.
Advocacy, education, prevention. Over 500 kids have been trained and certified in this peer-to-peer program. Kids helping kids stay away from opioids.
So we have to get on the prevention side. We have to stop it before it starts.
I know that he is absolutely driving every single day of the work that I'm doing. He wanted to heal people. He was the most caring, loving person that I ever have known in my life.
Toccoa Falls in North Georgia is a popular tourist draw.
We probably see 150 a day.
Just a few miles from the falls is a place that is busy every day of the week. The Pittard Clinic provides medication-assisted treatment to people with opioid use disorder. The majority of those served by the clinic are uninsured. Patients pay for medication and counseling.
They just say it's another thing that you get addicted to.
Brenda is a patient.
A lot of stuff messes my stomach up.
She says people in the community don't like that the clinic is here.
I think they think that if you are going to straighten up, then you need to not do anything. But I think those people are not in this position and they don't know.
Yeah, unfortunately, life sometimes doesn't come the way you'd like for it to.
Dr. Carl Smith retired from family practice to head up the clinic.
At any one point in time, 60 to 65% of our population is what I consider to be stable. They take their medication, they take it properly, they don't have any illicit drug use, they are doing better with their physical health, they are employed.
A lot of our patients are IV drug users, and they share drug equipment. And so we see a lot of hepatitis C in this population.
Untreated, hepatitis C can lead to liver disease, cirrhosis, and cancer. Imagine Hope, a company that works with healthcare providers, helped connect the clinic to a grant that would pay not only for testing, but for treatment for patients who tested positive for hepatitis C, a treatment that would normally cost $100,000 per patient.
Once we treat them, it's a 12-week treatment, and then we wait 90 days and we retest them. And so far, with the patients that we have treated, we've had 100% success.
We started this program in March of 2015 with just 5 clinics. We're now screening in 31 clinics.
Dr. Smith convinced Brenda to get tested for Hep C. She was positive, and she got treated.
Well, I kind of feel like he saved my life, you know, because I don't think I would have done it otherwise.
We've had a lot of overdose deaths in this neighborhood in particular.
The Little Five Points section of Atlanta is Andy Gish's neighborhood.
Lived here for about 20 years.
It's why on her day off from being an ER nurse, she's still on.
These are naloxone kits or Narcan kits.
Making sure businesses in the area have the overdose reversing drug naloxone in their first aid kits. It was a cause she came to after what she witnessed at her job.
They were coming in much worse shape. They were younger. It wasn't a typical overdose. It wasn't what we had seen before.
The synthetic opioid fentanyl had entered the opioid scene. Incredibly potent, just a few grains could be fatal. People who overdosed often didn't get help in time for fear of being arrested.
There are stories about people dying in the back seat of a car as their friends drove around for 4 hours, worried about going into the emergency room. I've already seen 3 friends die in front of me.
Gish got involved with Georgia Overdose Prevention, an advocacy group of volunteers. Many have lost someone to an overdose. She worked with them to help get Georgia's medical amnesty law passed.
The medical amnesty law in Georgia allows legal protection if someone is carrying a personal use amount of drugs or if they're carrying drug paraphernalia, if they're having an overdose. So if someone's having an overdose, they can call for help and not get charged for having drug paraphernalia or a personal use amount of drugs.
In her neighborhood, people were overdosing in public bathrooms and parking lots, so she went door to door, teaching and training business owners how to use naloxone.
There's a coffee shop in this neighborhood where someone had overdosed and died in the bathroom. Their manager reached out and said, please, can I get some of this naloxone? I don't want this to happen again. And I met her and trained her. Within 2 weeks, I got a phone call from her, and she had used it in the bathroom and reversed someone. We don't want to be the neighborhood where people die.
We're trying to reduce all the harms that we can.
You got it.
There is a lot to lug.
All right.
But they are always set up in time for lunch.
Feed them and they will come. Do you see that car? That car up there, that's where we're going. That car and that pecan tree. We are in the English Avenue community. On the streets, this is known as the Bluff.
There's 2 doses in here.
Atlanta Harm Reduction Coalition does this several times a week, goes into vulnerable communities.
You see that? So that goes right in the nose.
All right, 1, 2, 3, 4, 5, 6, 7, 8, get you 11. This is where outsiders know to come and buy drugs.
Do you need any condoms or naloxone?
Georgia's legislature voted to pass a bill legalizing syringe exchange in Georgia in 2019. The coalition has been doing it much longer, for 25 years.
67, 68, 69.
A steady stream of people come to eat.
It's a 3-course meal, dang!
To exchange their used needles for new ones.
8 in, 11 out.
To get the overdose reversing drug naloxone, or to be tested for HIV or hepatitis C. Harm Reduction co-founder Mona Bennett.
A judgment-free zone is vital. The people we serve are treated like crap almost everywhere else.
39 states now have syringe exchange programs. Many passed after what happened in Scott, Indiana.
In southern Indiana, made national headlines.
A rural area hit by the opioid crisis.
It tore through the community.
Among its 4,000 residents, 231 of them wound up with HIV from sharing needles. Almost 6% of the population.
It's gotten a lot better.
Drug use is still rampant, but syringe exchange helps stop the spread of HIV. And that is the foundation of harm reduction, reducing harm to the individual and harm to the broader public. Harm reduction also helps people into recovery.
We have had a lot of people come to us, Mona, I'm ready. 1, I'm ready to quit. 3. Harm reduction is a bridge to treatment.
We didn't get into this crisis overnight, so it's going to take a while to dig out of it.
A lot of people served by Atlanta Harm Reduction Coalition are uninsured, making access to treatment difficult.
I think that is something that
Cassandra Price is the director of the Office of Addictive Disease at the Georgia Department of Behavioral Health and Developmental Disabilities.
We're expanding treatment services to help them reach a state of recovery.
The state of Georgia has expanded from just 2 medication-assisted treatment programs for the uninsured to 21 since 2017. $4 million in state funding, in addition to federal funds, has increased the number of addiction recovery support centers across the state to 25. Approximately 2,000 Georgians have been treated using MAT thus far. The issue of stigma remains a problem, and this is part of the state's effort to change that.
Think about it, 20 years ago, would you have seen someone in recovery on a billboard, loud and proud?
Billboards throughout the state showing people in recovery from substance use disorder, putting a face on this crisis.
We want people to know that there's hope. This crisis is awful. We used our funding to get peer support focused on individuals who have lived experience using medications from opioid use.
I have to reach for the stars. That's right.
The state also works with nonprofits like the Georgia Council on Substance Abuse. 650 people in recovery throughout the state have been trained to be peer specialists, people who support other people working toward recovery.
We need more treatment in Georgia, am I right?
This weekend, the training is happening in the English Avenue neighborhood.
Number of people
Council Executive Director Neil Campbell.
Between 3 and 4 people a day are dying. A day. Wow. If it was Ebola, what would we be doing?
Be a national crisis.
Be a national crisis, we'd be figuring it out pretty quickly.
So let me ask you, what have we done well?
I'm a certified peer specialist.
Tony Sanchez has that lived experience, hard-lived.
So I come from a family of entrepreneurs.
Sanchez means drug dealers. Raised in the Bronx, he was addicted to opioids and is unflinching in sharing what he did to answer the cravings from his addiction.
I know what it feels like to leave my wife in the hospital when she's about to have surgery and go home and steal all her medications and still either sell them in the street or use them myself. You know what I mean? I know what it feels like to spend more time in jails and in prisons to the point that I thought that I belonged there and I didn't know how to function. I know what it feels like to come home and seeing all the pictures on the wall, and I'm not in any of those pictures.
In recovery for decades and living in Georgia, this home-owning married grandfather has lost track of how many people he has helped as a peer specialist. But within his own family, the losses continue.
My first cousin passed away in August of last year. My brother-in-law just died in September. My brother, he just told me that he overdosed in July, but they were able to bring him back Narcan, and because of stigma and shame, he didn't want to talk about it.
Sanchez is leading this event in Macon on mental health. He works for the state of Georgia, making his living fighting against the very disease that almost claimed his own life.
I'm the director of the Office of Recovery Transformation, a state job with a director's position, and I am a returned citizen. I spent so much time in prison, and they know, and they still pay me. My house is paid for. I'm a taxpayer. I'm a father. I'm a grandfather. I'm a business owner. I'm a member of my church. I'm a productive member of my community. I help to enhance my community. I show up. You know, I have purpose today.
Thank you.
Is life perfect? No, because life, you know what I mean? If we're breathing, we got to go through things. But I get to participate in life. I get to participate in life. I am no longer a spectator.
50% of surveyed Americans report that they know or have previously known someone who's addicted to pain relievers. It's a lot of people.
Half of us know someone affected, yet the stigma remains a big issue. Stigma for the person addicted, stigma for their families, stigma for the evidence-based treatment that is saving lives.
And I think so often, you know, families act ashamed of it. And if they act ashamed of it, what they accomplish is they reinforce the stigma of it. And if they reinforce the stigma of it, they're on the other side of public health, because stigma has no place in public health.
One of the most powerful ways to confront stigma is to speak out, to share our truth with others. And that's what CDC Director Dr. Robert Redfield is doing. A married father of 6, his son became addicted to opioids.
I really thought I probably was an expert, but I tell you, I had no concept of addiction until it entered my own family. And, you know, we have a great family, but I can tell you it almost ripped our family apart. I didn't realize that addiction is not a medical condition that confronts the individual only. It's definitely a family community medical illness that we're confronting. Information in Health in America. One of the gifts of being a doctor, if you really get into it, your patients become your friends, and you kind of learn more. I guess that's why I was shocked that I didn't quite understand this until it really entered my own family, because I really wish I understood what I did now. I would have probably been a better doctor to all of them.
He found himself in the all-too-common, frustrating position of trying to get his son help that would work, that would save him.
When I was looking for my own family member, tried to look at programs records, what was their percentage of treatment success? Well, you can't find it. I want to know their methods of treatment. I want to know what their outcomes are. We love our child that got involved in this dearly. It was a great gift. I'm happy he's 4 years from recovery now. I think it's a great gift that he was able to decide to accept treatment and go into recovery. But we would go to gatherings and, you know, no one would talk about addiction. And then my wife would make some comment about our son's journey. And then about 5 minutes later, a couple would cross over to come talk to us and say their son just overdosed. And then, you know, 10 minutes later, somebody else would say their son's still struggling, they don't know how to get it. Before the dinner was over, you know, 50% of the people that were at this room were struggling with addiction somewhere in their family.
Redfield says the importance of medication-assisted treatment wouldn't exclude support programs or counseling, but it's an evidence-based way to get help.
I can tell you that if you go into a safe syringe exchange program, you're 3 to 5 times more likely to go into treatment for your addiction. I want people to go into treatment for addiction.
As for the opioid crisis in Georgia,
The challenge with Georgia, it's very diffuse. You know, some people may want to think that the biggest problems are in the urban areas like Atlanta. The truth is, much of the problem is actually out in the rural counties. Here in Georgia, you have certain counties that have received 50 million tablets of oxycodone for a county, enough to treat every single man, woman, and child in the county.
Redfield says the prescription monitoring programs have cut opioid prescriptions by 60%.
I think we have to say it the way it is. The bottom line is the prescription for an opioid is one of the most critical decisions a provider would make. I mean, I didn't know this as a provider until I became CDC director, that the risk of long-term addiction to opioids was 2 to 6% from a single prescription.
Redfield says the CDC is notified of all drug overdose deaths across the country within 48 hours, and non-fatal overdose data is gathered weekly.
When I became CDC director and I was looking at data that was 2 years old, it's going to take us a while. But I had no question we're going to get out of it. And ultimately, science is going to get us out of it. But in the interim, we have to use the tools we have now to the best of our ability. But we can't lose sight of the possible.
Those words come from experience as a scientist, physician, and father.
My wife and I just broke down in tears maybe 16, 18 months after he was in recovery, when he called one day and he said, you got your son back.
For thousands across the country and in our communities, the price of this crisis has been too high, the losses too deep. But resilience.
You have to have the advocacy, the education, and the prevention.
And resolve.
We support all pathways to recovery.
Are driving forces in making sure this doesn't happen to others. Institutions linking arms, translating the science, breaking down barriers to treatment.
I got sober in December of 2006.
People sharing their stories.
I can do a lot of stuff that I didn't think I was able to do. So that's kind of how I feel.
Getting rid of stigma.
It is a community with a lot of needs, but it's also a community with a lot of heart.
The goal, quite simply, is this.
It is.
Intact families on the other side.
Our life will never be the same, but that's not a bad thing.
I'm joined by Frank and Karen Boykin, Stephen's parents. Thanks so much for joining us today, Frank and Karen. It's great to see you again.
It's good to see you as well, Jay.
You know, I know we condensed several years of a difficult journey into several minutes. So I'd like to go back to when Stephen was taking opioids before you found out. Did you ever suspect he was doing drugs?
Not really. At the time, he was in college. So we assumed he was drinking, possibly smoking pot, but never in a million years did we think he was using heroin.
I want to ask you something that I asked Cami Wolf-Rice a little bit earlier in the show, which is, what do you wish you had known at the beginning of this journey?
I wish we had known the signs of opiate addiction, but we didn't. But now we do. And some of those signs that I wish we knew then, they would wear long sleeve shirts, even on the hottest summer day. And I guess that was to hide track marks. Their eyes are, their pupils are very small, and they may have dark circles under their eyes. Their voice may be very raspy, and there may be extreme weight loss. They may nod off in mid-conversation. They scratch their face or arms or legs constantly. And he was always broke, even though we were financially supporting him. So even if they should have enough money to live on, they never have enough. They're always asking for more. I wish we had known that.
And so you saw those signs in Stephen, and you just chalked it up to, well, you know, he's just scratching, or, I mean, right, just like a...
He's strawberry blonde. He has always had sensitive skin, or he's always been on the skinny side. He's in college. He's coming home to study for finals. He's tired. So we just kind of justified that he can manage money, his life, that sort of thing. And it just never occurred to us that it would be heroin use. Never.
You know, there are a couple of things that I wish I had known early on. I would say the first is that, you know, addiction is not a moral failure. It's a disease. And it's no different than any other disease. It is a chronic disease, a little bit like diabetes, but it can be treated. And it can be treated with 12-step program, therapy, other types of programs, and medication. Like with diabetes, insulation it's not going to cure diabetes, but you can get it under control. And the medication that we heard with Stephen that he took, buprenorphine or Suboxone, had we known about that when he first went into rehabs, who knows? Maybe he would have been sober 2 or 3 years earlier.
Frank, what was your experience of trying to get Stephen help in Georgia?
You know, there are good rehab units here in Georgia, in Atlanta. But I would say that our experience was not good. It was difficult. And the decision to send Stephen across the country to Hazleton Betty Ford, all the way out to California, that was a hard decision that we made. But it was absolutely the right thing to do. And you know, the other good thing that came out of that, we, with the help of our good friend, Tom Johnson, we were able to realize our dream, the dream of bringing Hazleton Betty Ford here to Atlanta to partner with Emory Healthcare and to provide a state-of-the-art facility that would address addiction for treatment, for education, and for research. What a great asset that's going to be to have here, right here in Atlanta and across the state of Georgia. Tremendous resource to treat addiction.
And to create something that wasn't available that you needed for your own son.
Absolutely.
Yes.
Absolutely.
What advice do you have for families who are in the position right now that you were in years ago?
I think the first step is to learn everything you can about addiction and recovery. I think it's important to be open to more than one path to recovery. In the beginning, we just highly relied on the 12 steps and traditional treatment. And when we became open to medically assisted treatment, that's when Stephen started to get better. And I wish we had been more open to that in the beginning. And I think it's important that you and your family get into counseling, get therapy, and join a 12-step support group. They provide a community for you. You don't feel so alone. And working the 12 steps is just a great philosophy, a way that we all should be living our lives. And it just helps us to stay connected to each other in a more healthy way. And we found that through Nor-Anon, the narcotics part of like Al-Anon.
Last question, how is Stephen doing?
I think he's doing really good. 2 years ago, he married a wonderful woman named Cece, and they have a great life in California, a great marriage, and they're both supportive of each other. I think that when he started his vintage clothing store in San Diego, that gave him a purpose and a passion. And the good thing, it's very successful. And lastly, he's been sober for over 4 years, thanks to Suboxone. So Stephen is in a really good place right now.
Absolutely.
I love hearing that. Karen and Frank Boykin, thank you so much. Sharing your story is going to help a lot of other families. We appreciate you.
Thank you.
Thank you.
I've brought our 4 experts together to continue having this discussion, and now we are going to bring your questions to the experts. And Dr. Seppala, I'm going to direct the first question to you, and here it is. I am on medication-assisted treatment, and I have been turned away from 12-step meetings and told I'm not in recovery because I take medicine. I think the rift in the community is still a problem. Can you talk about this?
Yeah, unfortunately, it really still is a problem, and worse in some parts of the country. And we've had to face this for a lot of our patients, and we actually call it stigma management because we try and prepare them. Nonetheless, the stigma is about the use of the medications, and yet most people don't stay sober. And with opioids, the risk of overdose, especially after a period of abstinence, is tremendous. And we cannot allow, the 72,000 or more overdose deaths per year to continue. So we need to do everything we can to help people. And you can find meetings that are favorable to the use of medications. We do that within the communities. We have treatment programs, and I would suggest calling different treatment programs to ask about such meetings. Also, we've found that Alcoholics Anonymous meetings are more favorable to medication use than Narcotics Anonymous meetings, where their national group has kind of forbidden that to some degree, and biases exist. So it's really a matter of, finding other people in recovery, asking them about favorable meetings, talking to treatment centers, other addiction experts to find some place you can get to safe meetings where they're not going to give you a hard time about the use of your medication.
Dr. Welsh, another question from a viewer is, we have a clinic in our town that gives medication to people who are addicted to opioids. We don't see this as helping our town. How can this possibly be a good thing?
Well, stigma really is a significant barrier to receiving treatment and can be both internal, meaning the person experiences some degree of shame about their disease, or external, where they are shamed by others. We really wouldn't stigmatize a clinic starting in our community that manages diabetes. Similar to diabetes, addiction is also a chronic disease. Just like patients with diabetes take insulin to manage their condition, medication for opioid use disorder treats the symptoms of a substance use disorder, such as cravings and withdrawal. And when properly prescribed, these medications do not cause a high. Individuals stabilized on medication for opioid use disorder can achieve recovery because they're not experiencing other signs of an active substance use disorder, such as loss of control or giving up important activities because of drug use. Data also demonstrates that 90% of people with opioid use disorder who detox only and do not enter residential treatment will drop out of treatment and or resume opioid use within 2 weeks. Providing treatment really helps communities.
Thank you, Dr. Welsh. We have a bunch of other questions, and any of you can answer as you wish. How do I safely get rid of opioids?
Well, I'll take that one, and I think that is a fantastic question because it really amplifies the importance of discussing safe storage and disposal. And so I would say if anyone has opioid medications that they are taking as prescribed by their physician, they should make sure that they are properly stored away. They may even need to be locked away so that only the person who is prescribed the medication has access to the medication. And then we get to the important question of disposal. And I would say that the first thing I don't want folks to do is flush the meds down the toilet. So I want everyone not to do that. And then there are other ways. You can dispose of the meds in kitty litter, maybe purchase kitty litter, put the meds in kitty litter, and then put them in the trash. This is an important conversation to have with your pharmacist and your physician. At the very beginning, when you're prescribed the medication, how can I dispose of these medications if I have extra? In some pharmacies, they have drop boxes. At some law enforcement locations, they have drop boxes. Sometimes there are mailers available. And I will say that innovation is playing a role here. I talked to one company and they had a little packet of a material that all you had to do was pour it into the pill bottle, it would gel, and then you could throw that away. So the key issue is this is an important conversation to have. There are many options, so I would talk to your pharmacist and your doctor when you are first getting the prescription.
Thanks, Dr. Harris. Similar question as far as how to get something. Where can people get naloxone or Narcan? And this person says, in case I ever need it to help someone.
So I'm happy to start. Georgia, like many other states, has taken really important steps to make Narcan available. There is a standing order so that anyone who wants to access it through their local pharmacy is able to get access to this life-saving tool. And I'm also happy to report that even individuals who are uninsured or might want to access it through a local nonprofit can reach out to the Atlanta Harm Reduction Coalition or the Georgia Opioid Prevention Program, and just ask for it, and it's made available to individuals. Our organization has also made it available to first responders. Anywhere we can, we want to encourage people to reach out, get it in their hands, especially when they know loved ones are at risk.
Thank you, Commissioner. Next question. My daughter is addicted and has relapsed twice and has overdosed. We cannot afford inpatient treatment. No one has ever recommended medication-assisted treatment. I'm afraid she will die from an overdose. What can I do?
Let me start with that one and give some general information, because most treatment for opioid use disorder is done on an outpatient basis, doesn't require the expense of a residential stay. And she could either see a medication provider or go to an outpatient program like Dr. Welsh runs at Emory. And I know there's other resources all over Georgia that could provide such medications, but the important piece is that people can access these medications without going to residential treatment and get the support services necessary.
Commissioner, would you like to add to that?
Yes, I'm happy to let folks know some really important resources that are available in Georgia. And they are available through funds from the federal government, provides funds to each state. In Georgia, the Department of Behavioral Health and Developmental Disabilities has put a priority on making medication-assisted treatment available, particularly for people who are uninsured. And so with monies that we've received through the State Opioid Response Grant, we've invested in standing up over 23 medication-assisted treatment sites that are available to individuals who are uninsured or do not have ability to pay, so they can still walk in, access treatment. I also want to let folks in Georgia know that the Georgia Crisis and Access Line is a 24-hour hotline staffed by licensed clinicians where you can call. Tell somebody where you are, what location you're in, and they can direct you actually to the local resources that are available in your community. And we really want to encourage people at that first sign where someone says, I need help, I want help, or you're looking, go ahead and make that call.
Those 23 centers you're talking about, is it a case where people have to be referred by a primary care physician, or can people contact them directly to get help? Because sometimes I feel when there are a lot of steps, people are less likely to do something. Is it a pretty direct shot to be able to get served by those centers?
Absolutely. The idea is you should even be able to walk in and at least have the conversation, right. I'm here, I'm seeking help, or I'm seeking help for my loved one. And if they can't help you right there, they can certainly direct you to how you can make that happen. We want to make it as easy as possible for people to access the treatment that they need.
Excellent.
And if I could add a broader point,
sure.
Because I think people equate treatment with residential or inpatient. And I think we need to make sure that it's about the treatment opportunity that best fits the individual need of the person. There is no one-size-fits-all approach. There are outpatient opportunities. And so I want everyone to broaden their horizon about what a treatment opportunity actually is.
Especially because not everyone can afford to do an inpatient treatment. Knowing that there are other options open up so many avenues for people.
Absolutely.
Our next question is, where do things stand with access to treatment for people? How are we breaking through barriers to expand that access? Who wants to take that one for us?
Well, I will start with a broader approach nationwide because the last set of data we looked at, and it does depend on where you live, but only 2 in 10 patients who wanted access to medication-assisted treatment, which again is evidence-based, had access to that treatment. That is 2 in 10. That is totally unacceptable. Now, we are seeing more and more treatment opportunities available, but we have a long way to go. And I really was very glad to see in Georgia that there are more and more treatment opportunities for those who don't have any insurance. So I think we are improving, but we still have a long ways to go before we make sure that everyone has an equitable opportunity for access to medication-assisted treatment.
What about the COVID impacts that we're seeing, these overdose increases that we've seen in the state of Georgia since March when we shut down? What is our takeaway from that? What do we do with that information other than be very concerned? How do we take that information and move it into action, and how we react to it? Anybody have thoughts on that?
I'm happy to start and really raise the concept of the importance of peer support. And when we use that term in the context of opioid recovery and treatment, we're talking about people who have been through their own opioid struggle, are on the other side of it, and then are trained to help individuals. So peers are active in Georgia all around the state, and they have embraced the opportunity to take action during COVID. And they're having recovery meetings, online, virtual recovery meetings. And there's also a warm line in the state of Georgia, where if you just want to say, I'm not in crisis, but I need to talk to somebody, I need help. We also have peers. There's a peer on the other end of the line to listen, to talk you through, not necessarily to do anything, but just to be there to listen. We've also placed peers in emergency department rooms where after an overdose, rather than just necessarily talking to a healthcare or medical professional, they might want to have the next conversation with a person who's been there. Peers are right there at the other end saying, let's talk together about what's going to happen next. So I think grasping that first moment where a person says, this isn't the way I want to live, I want to find help, having a connection of another individual who's been there. We've tried to really make it possible for peers to support other individuals all throughout the state. So there are peer recovery centers in communities all across Georgia. Again, places you can walk in and say, can I talk to someone? I think I need help.
Excellent. Dr. Seppala, I'm sorry.
If I could add,
Go right
I think
ahead.
the other learning moment that we've had during COVID is the opportunity for telehealth and access through services through telehealth. And my co-panelists may be able to more specifically talk about what's here in Georgia, but I know nationally, at the federal level, there were several regulations and restrictions that were loosened during this time that really incentivize access to treatment at all levels through telehealth. And so I think that's been an important learning moment. Now we will still need to learn about that because we have to make sure that privacy and confidentiality are valued even through telehealth. And we still have to look at some regulations and barriers and actually payer requirements that limit access. And here in Georgia, we have to think about access to broadband. Because if you live in a rural area or an area where you don't have access to broadband, then telehealth, though it may be available, may not be available to you. But I think that is an important learning moment through COVID.
I think that's very true. You know, we've had the conversation for years about telehealth was coming, and COVID forced everyone to embrace it, right, in an ambitious way. And now that we see it is really becoming a lifeline for people. I know that there's work to be done in that area, but it's encouraging to see. Dr. Harris, Dr. Seppala, Dr. Welsh, and Commissioner Fitzgerald, thank you so much for your insight and advice today.
Thank you.
My pleasure.
Thank you.
Thank you.
Finally tonight, a follow-up conversation with Tony Sanchez, who was featured in our show tonight. Tony is the director of the Office of Recovery Transformation at the Georgia Department of Behavioral Health and Developmental Disabilities. Tony, it is great to see you again. Thank you for being with us.
Thank you for the opportunity to be on the show, Jay. It is good to see you as well.
You know, what I loved about when we met is that you were very honest with us about your journey. And as we say, you have true lived experience. So for the people watching right now, if they know or love someone with opioid use disorder, what is your advice to the families of those people?
First and foremost, that my heart goes out to them. I know that it's a very, very difficult time. One of the things that I would really, really stress is to educate themselves about the illness, about the misuse of drugs. Education, knowledge is power. You know, one of the things that tends to happen is that people start to internalize the stigma, or believing that they did something wrong. And I truly believe that through education, they can learn that that drug dependence, drug misuse doesn't know socioeconomic barriers. It doesn't know color. It can happen to anyone, and that it is not their fault. I would also encourage them to remember their loved ones as their loved ones and not judge them by their behavior. That this is an illness, that this is a chronic medical health condition that could be treated, and that recovery is not only possible, recovery should be the expectation.
We talked in the interview about your family, but you also wanted to point out a lot of them are regular, good, hardworking people who loved you through every bit of your life and everything that you've been through.
Yeah, thank you for saying that, Jay. The statement that I made in our earlier interview about some of my families being drug dealers is true, but the majority of my family, especially my parents, are hardworking individuals who, as a matter of fact, they've been married for 60 years. They raised a family together. Both my parents work. They dropped out of this school at the 8th grade so they can go to work, and they stress education. And so I want to honor my family, because they are hardworking, good American people who raised their family the best that they could with what they had.
Tony, the last thing I would like to talk to you about, and for you to take us out on this note in our last minute, is you say recovery is available to us all. Talk to me about that. Recovery available to us all? Because for some people, I think they feel that it's not within reach, or they can't get access to resources. So talk to me about that.
Well, I mean, we know even through this pandemic that we're in now, we can see the health disparity. However, recovery is everyone's responsibility as well. And recovery should be available. If it is a medical health, if it's a chronic medical health condition, then why not make it available to everyone? And everyone should have the opportunity to recover. And it is our responsibility to make those opportunities available so that people could take their rightful place in their families, in their communities, and be able to live their best lives.
Tony Sanchez, thank you so much for joining us today and talking with us. And I know that I'm going to see you again. So thank you for the time.
Thank you, Jay. Thank you.
One last reminder, you can call the Georgia Crisis and Access Hotline number at the bottom of the screen to get connected to state resources for yourself or a loved one. That number is 1-800-715-4225. Georgia Public Broadcasting and I would like to thank the Georgia Department of Behavioral Health and Developmental Disabilities for their incredible support and partnership on this project. And a heartfelt thank you to our sponsor, Southern Company Foundation, for supporting this important public health discourse. This brings us to the end of our program tonight, but we have just begun to have this important conversation, and our pledge to you is that we will continue to have it, because it is only when we openly and actively confront an issue together that we can make strides against it for the good of all Georgians and their families. Thank you for sharing your time with us. Good night.
Support for Your Fantastic Mind, provided by Southern Company Foundation. Support for Your Fantastic Mind, provided by the Georgia Department of Behavioral Health and Developmental Disabilities. For more information, visit opioidresponse.info.
We, the people of Georgia, are greater. Greater than the opioid epidemic that's taking our loved ones and tearing families apart. And together with DBHDD's State Opioid Response Team and our network of partners, we're taking action by increasing access to prevention programs, by making it easier to get support, by reversing overdoses with life-saving naloxone, and by putting youth prevention programs first. From Atlanta to Augusta to Albany, there are many things you can do to fight stigma and stop the hurting, like learning to correctly handle pain medication, by safely disposing unused pills and acting quickly to stop an overdose. Together, we're working hard to solve this crisis, and with your help, we can overcome it. United, we are greater than the opioid epidemic, because united, we are Georgia. Learn how you can get involved right now at opioidresponse.info.